A very good morning to our honorable judges and my fellow colleague. I'm Dr. Wong Chee Soon, currently a MDA SCATE student under Prof. Niao and Dr. Daniel. Today, I would like to present my humble research with the title of Mandibular buccal shaft dimension in selected Malaysian population, a CBCK study. Before we dive into the research topic, let's have a brief introduction of the buccal shaft. According to the Medical Dictionary of the Dental Profession by Farex 2012, buccal shaft is a broad flat surface of the posterior mandible buccal to the teeth or alveolar ridge. Anatomically speaking, it is bounded medially to the crest of the ridge, distally to the retromolar pad, and laterally to the external oblique ridge. The buccal shaft has been a very useful region for many dental specialists. Throughout the years, buccal shaft is popular among dental practitioners as a very good source of autogenous bone, mainly for alveolar ridge augmentation and orthodontic surgery. Apart from this surgery, recently this region has also gained a lot of interest among orthodontists to insert mini implant. Besides that, this area also provides as a primary stress-bearing area for mandibular removable prosthesis. Through this buccal bone is also where endodontic microsurgery or episectomy of the mandibular posterior teeth is being performed. The study of mandibular anatomy has come a long way since the dawn of dentistry. With the advancement of radiographical technology, we are now able to incorporate CBCT in our daily practices. As the complexity of dental treatment increases, we need a better understanding of mandibular anatomy and further information of what's within or behind the bone. With the acquired knowledge, we are able to perform better and safer surgery at that area. Also, when we first started looking through all the previous research articles regarding buccal shaft, we found that most of the previous studies were mostly on Caucasian patients. Therefore, we had the idea of comparing buccal shaft dimension among Malaysian population, as the main reason is that Malaysians are made up of three major ethnicities: Malay, Chinese, and Indian, who also happen to represent the Asian population in general. Our aim of study is to perform radiological study of the buccal shaft and to investigate the distance of the mandibular canal of prevalence of bifid mandibular canal. Followed by our objective is to determine the bone thicknesses adjacent posterior root apexes and mandibular canal and proximity of the inferior alveolar nerve. From there, we can work out the amount of bone that can be harvested without inflicting harm to the adjacent teeth and branches of the inferior alveolar nerve. Moving on to our material and method of our research, we included patients who attended the oral radiology division of the Faculty of Dentistry, University of Malaya during the period of 2010 to 2020 to obtain scan for various other conditions affecting the upper and or lower jaws. Here is a disclaimer that no CBCT were taken solely for the research purposes. And according to the sample size calculation formula used by Chakowicz in 2016, the amount of data that we needed for our study will be 104.7 for our data to be statistically significant. For our study, we include healthy subjects of both gender from three main ethnic groups in Malaysia, namely Malay, Chinese, and Indian, and with the presence of accessory canal complication and must be connected to the mandibular canal. For our study, we exclude patients with a history of trauma, existing pathological disorder, congenital disorder, severe malocclusion, a history of surgical intervention, and lastly, severely atrophic mandible. We also will not accept any CBCT images that appear distorted or blurred. We have included a total of 235 sites of CBCT in our study, consisting of three major ethnicities, and patients were placed in four different groups according to their age. Group 1 will be 18 years old to 24 years old, Group 2 will be 25 to 31 years old, Group 3 will be 32 to 38 years old, and Group 4, 39 to 45 years old. The following landmarks were measured after calibration on axial, coronal, and surgical axis. The first one will be the distal buccal cups of the mandibular first molar, followed by mesial buccal and distal buccal cups of the mandibular second molar, and lastly, the mesial buccal and distal buccal cups of the mandibular third molar. Here is an overview of how the measurement was done. For cases where the third molar was not present, The second molar will be superimposed as an imaginary tooth over this region to be used as a landmark. One of the parameters that we use in our study was cortical bone thickness, which is defined as the dimension of cortical bone measured from the midpoint of the osseous ledge, parallel to the contour of the buccal root surface of this tooth. Another parameter that we use in our study is the buccal shaft bone width, which is defined as the total amount of bone available in the buccal lingual direction from 4 mm and 8 mm of CEJ. The inferior alveolar nerve was first digitally traced using a tool in the software, followed by a measurement made at cross-sectional image of the same tree site, the buccal to the distal buccal cups of the mandibular first molar, followed by the mesial buccal and distal buccal cups of the second molar. The following dimensions were taken from the nerve. Cn stands for the bone directly superior to the nerve. Bn stands for the bone directly buccal to the nerve. Ln stands for the bone directly lingual to the nerve. And lastly, In stands for the bone directly inferior to the nerve. The pattern of bifid mandibular canal was firstly recorded, later classified as described by Naito et al. In 2009. The diameter of the bifid mandibular canal will then measured and will be classified as described by Kuribayashi et al. In 2010. The position of the bifid mandibular canal in relation to the buccal shaft was recorded. Now let's move on to our result. For the Crestal bone thicknesses, it ranges from 6.1 mm to 6.8 mm, with the thickest area being at the distal buccal bone of the first molar. When compared between gender, there is no statistically significance. For age, Group 1 has the highest thicknesses, while Group 4 has the lowest thicknesses. Also, there is no statistically significant when compared among ethnic groups. As for buccal shaft bone width, the buccal bone width was the highest at 8 mm below CEJ, at 4 mm level at every site of measurement. The distal buccal of third molar are the highest among the rest of the group. Group 4 has the highest bone width, and female has more bone width compared to male at 4 mm. And Chinese patient has the highest bone width compared to the rest. Moving on to the result of the IAN. For the Crestal measurement, the distal buccal cups of the second molar has the lowest measurement. Group 3 has the highest Crestal measurement among the rest of the group. Male patient has the highest CN. Lastly, the Malay patient also has the highest CN among the rest of the group. Meanwhile, for the buccal measurement, the distal buccal of second molar has the highest value among the rest. Group 1 also has the highest value among the rest, followed by Chinese patient, who has the highest BN compared to the rest of the group. However, it's not statistically different among gender. For the lingual measurement, the distal buccal of second molar still has the highest LN among the rest of the group. This time, Group 4 are leading among all the age group, and Chinese patients are still the highest LN value compared to the rest of the group. And male has 6% more LN to female patient, which is significant. Lastly, for the inferior dimension of the nerve, the distal buccal of first molar still has the highest IN among the group. Group 3 is still a leader, and Chinese patient has the highest IN among the group. However, there's no statistically different among gender. Most of our mandibular canal are clearly observed, with 37 sites shows the presence of bifid mandibular canal. There's no subject present with bilateral mandibular canal in our cases. With the data on hand, now we can work out the volume of bone that can be harvested safely. According to Verdugo in 2014, Lee Stavola in 2017, and Para and colleagues in 2018, we can approximately work out an average of 0.8 cm3 of bone. With this, I'm able to come up with a simulation to estimate the height and the depth that we can go without inflicting any harm to the adjacent root apexes and also the nerve. As we can see from the simulation, we can still obtain a bone block with a 1 cm height and 0.4 cm depth. As a conclusion, I think buccal shaft is still a good source of autologous bone block graft, and the distal buccal of the second molar provides a more favorable site for orthodontic bone screw due to its thicker cortical bone thickness, and a thicker graft also can be obtained at the distal buccal of second molar. With this, I would like to end my presentation with a big thank you and hope to see you guys during the Q&A session.